Good morning, ladies and gentlemen. We warmly welcome you all to the third day. This is the last day of our main Congress, and again, it's going to be an exciting day with a lot of panel discussions and expert discussions. So the first one to start with, we'll be commencing now with the SLENDO 2023 Expert Communication in Diabetes, the session. And I would like to invite Dr. Dulani Kottahachchi, the Secretary of the Sri Lanka College of Endocrinologists, to please introduce the main speaker, Professor Peter Lin, and then to commence the program there onwards. Thank you.
A very good morning, ladies and gentlemen. This Expert Communication in Diabetes Symposium is a collaborative venture with Sri Lanka College of Cardiologists and Sri Lanka College of Endocrinologists. I would like to introduce our esteemed guest speaker today, Dr. Peter J. Lin, MD, CCFP. Dr. Lin had his primary education at Faculty of Medicine at the University of Toronto. He has served in the past as a medical director at the University of Toronto's Health and Wellness Centre at Scarborough for 7 years. Currently, he is the Director of Primary Care Initiatives at the Canadian Heart Research Centre. He has been an editor for Focus on Cardiology, Perspectives in Cardiology, and in the Canadian Alzheimer's Disease Review. He has delivered many lectures nationally and internationally, and he has received many awards for his contributions. May I now invite Dr. Peter Lin to the stage to deliver his talk on SGLT2 inhibitors, Know Where It Stands, Trial Evidence to Real Practice. Over to you, Dr. Lin.
Thank you very much. Thank you for turning up on a Sunday morning, and I really appreciate that. And I want to thank our organizers, and I want to thank the panel. As you saw, the panel that we'll be discussing up here is all the top experts here and abroad. So I'm really pleased to be part of this. And what I'll do is I'll talk about the nonsense of SGLT2, and the panel discussion is where we get into the useful pieces of information, okay? So I'll talk about nonsense, so wait for it. In about 40 minutes, you'll get the good stuff that comes. And I've got this picture up here talking about SGLT2 inhibitors. Initially, we just thought about them as glucose medications, things that can make you pee out sugar and therefore drive down your A1C. And by losing some sugar, you also lose some weight, and your blood pressure may come down. So we thought that it was addressing many issues, and so therefore the endocrinologists love this medication very much. Cardiologists really couldn't care less about diabetes care because controlling sugar alone takes 10 to 20 years before you get cardiovascular benefits, whereas doing lipids, antiplatelet, blood pressure control can give you good results within 3 to 5 years. And so therefore cardiologists were mainly focused on the shorter term where you can get the benefit within 3 to 5 years. Nephrologists were always interested in medications that can lower sugar because it can lower dialysis risk and all those other things. But they themselves were not that interested unless these medications can maybe decrease the decline of kidney function more than just sugar control. Because otherwise I can do it with insulin, I can do it with DPP-4 inhibitors because many things can lower sugar. So therefore, the main focus was endocrinologists loving the SGLT2. And as you've seen recently, there's now data that says there's benefit in heart failure, there's benefit in renal failure, there's benefit in people with diabetes and without diabetes. So all of a sudden, we have a panel that includes endocrinologists, nephrologists, cardiologists, that all feel that these medications are now very important for us as we move forward. So let's get started. So these are my conflict of interest. So I've worked with all these companies before in education. I don't do any clinical trials, and I don't own any patents. So I thought I'd start off with one funny. And so this is President Biden, and he's saying, like, you know, to President Obama, I've been trying to call you all day. And then President Obama says, Joe, that's your calculator, okay? So you're using the wrong device. So definitely we have some issues, okay? And I think many of you could see that happening right now. So the idea is that we need to know what the tools are good for. So what is an SGLT2 inhibitor good for? And then we can figure out where we can use it and which patients to use it in. This paper I pull out because it is specific to Sri Lanka. We have some experts here that will be on the panel that have been doing a lot of good work here locally and getting some good data for patients that you and I might see. So we've got people in Canada looking at local data, and of course here, this is a publication about Sri Lankan data, which we will talk more about in the panel discussion. I'm very interested in seeing that information as well. So I was thinking about how to put this talk together, And so I thought about President Obama. This was when he was young. This was before he became president. He's a good-looking guy, right? And then when he became president and he had to deal with Trump and everything, he looks like this now, so very big difference. And so these are the two types of patients I want you to think about, person with disease already and person without disease. So the concept of prevention and treatment in the same person. So if you look at the life cycle of any patient, let's talk about cardiovascular disease, there's at some point where you have an event, and after that event, then we call you secondary prevention. In other words, you had the first event, and now we're trying to prevent the event from happening again. So let's say a heart attack, heart failure, any of those things. And so therefore, the old Obama might sit in this particular category. The young Obama sits in the primary prevention, hasn't had the event yet, and our goal is to prevent that person from having whatever event it is, heart failure, heart disease, kidney disease, whatever the condition is. And so I want you to think about patients in those two buckets. So let's say old Obama says, I'm short of breath going upstairs. You happen to do an ejection fraction echo, and it says 38%. So he has reduced ejection fraction heart failure. And so therefore, what are you going to do for old Obama in terms of treatment? And how do the SGLT2 inhibitors fit in? And you know the studies already. You've seen them before, but I'm just going to pull them together. For example, DAPA-HF study. And that was heart failure in reduced ejection fraction. These are the patients that had a heart attack. They cannot pump forward. And to make it interesting, they gave it to patients with diabetes and without diabetes. And people thought they were mad. You know, why would you give a diabetes drugs to people without diabetes? And you have to remember SGLT inhibitors basically stands for sodium glucose cotransporter inhibitors. So not only is it managing glucose, it's helping you manage sodium. And if we can manage sodium well, that might be good for heart failure. So therefore, there's a good rationale why we would give this to people with heart failure that do not have diabetes as well. And if you look at the overall results, it was very impressive. Here's the placebo group, which means usual care for heart failure, so RAS blockade, et cetera, et cetera. And then if you add on dapagliflozin 10 milligrams, you get a nice 26% reduction. And for those that like absolute numbers, the absolute difference between the two curves is 4.9%. And for those that like number needed to treat, you just take that 4.9% and divide it into 100, and the number needed to treat is 21. And if you see that little 2 at the bottom, it means that you treat them for 2 years. So if you treat 21 people with dapagliflozin on top for 2 years, you'll prevent one of those people from having one of these bad events. So the cardiologists all of a sudden loved this medication because it was easy to use. You can just add it on top of everything else. Whereas when we're talking about neprilysin inhibitors like Entresto, it's more complicated, right? You have to take away the ACE inhibitor, take away the ARB, and then you could start this medication, and it's twice a day, and there's 3 titrations. Whereas with dapagliflozin, you don't have to take anything away. You just put it on top, 10 milligrams, single dose. So it made it very easy for people in primary care to do this as well as in cardiology. And interestingly, should we wait? And the answer is no, because if you look in the first month, the graphs are already separating. So that means within the first month of therapy, you're already seeing a difference between the two groups. So the key here is to not wait, because you can get the benefit very early. Now, because it's so early, it's unlikely that it's doing remodeling of the heart or anything like that. Most likely it's hemodynamic, so something to do with sodium management, something like that. And that's why we're seeing benefits very early on without needing the heart muscle to become healthy. So earlier on treatment would be good for your patients with heart failure. What about diabetes, no diabetes? So the graph on the left is diabetes people, and you can see very good numbers there. And no diabetes is the one on the right, and the graphs look almost identical. So in other words, nothing to do with sugar control, more to do with the sodium management, most likely, in terms of the mechanism. And so all of a sudden, it made sense that we give it to people with heart failure, reduced ejection fraction, diabetes, no diabetes, doesn't matter. And so therefore, this becomes the 4th pillar of heart failure therapy. So that's why all the guidelines updated and said you must include SGLT2 inhibitors as well. What about the young Obama? Can we prevent him from having heart failure? So let's say he's 61 years of age, he's had type 2 diabetes for 4 years, and in this case, we're going to specifically look at diabetes patients, and he's just got hypertension as a risk factor. So can we prevent heart failure in him? Do we have any data around this? So we have to go look back at our studies. So here are the SGLT2 inhibitor trials that look for cardiovascular events. And you'll remember Avandia, rosiglitazone, killed people, right? That's what they said, the drug killed people. And ever since then, the FDA said, you must do a safety data. You must show me that you don't cause any harm. So that's why all these new drugs had to do these cardiovascular outcome trials. And you can think about the patient as secondary prevention, primary prevention. And the very first study that we saw was empagliflozin study, so EMPA-REG, which used all secondary prevention patients. Because the FDA said, show me that your drugs are safe. So they took people that had heart attacks and strokes, gave them the drug, and said, do we cause any harm? And so that's why that study was designed with all the people in secondary prevention. Canagliflozin then said, wait a second, we're going to include some primary prevention patients. So about 3,000 patients they included in there, because those patients are a lot of the people that we treat with diabetes. And then finally with Dphil, which is dapagliflozin, that's the one with Farxiga where they included 10,000 people in primary prevention. And the reason why they included such a huge amount is because 75% of the world's patients with diabetes are primary prevention. So they have not had a heart attack yet or a stroke or anything like that. So we need to know what benefit these drugs may have on them, and you need a large number of people to study that. So that's the biggest difference between the three studies, is one has a huge number of people in primary prevention. I'll show you why that might be important in a second. So what they do is these meta-analysis is they take all these studies and then they put them together. And what they're hoping for is to say, is this a class effect or are there differences amongst the classmates? And so when they looked at people that had secondary prevention for heart failure hospitalization, just that particular item, you could see that for secondary prevention, if you had a heart attack or a stroke, all of them have benefit. So empagliflozin works, canagliflozin works, dapagliflozin works. So if you've had an event already, and I give you one of these SGLT2s, you're not likely to go into hospital with heart failure. In primary prevention, it's different, and here is the numbers. And it's different because in the EMPA-REG study, there were no patients in primary prevention. Remember, they were all secondary prevention. So which means there's no data saying that it works in primary prevention people. It may very well work, it's just they didn't study the population. Canagliflozin had some, and you could see that it is heading in the right direction, but the tail crosses over 1. So therefore, we would say that there's no statistical benefit of that. So the only one that had it was Dphil, which was dapagliflozin, where there was a clear benefit of heart failure hospitalization reduction. And so what the Dphil study did, because of that 10,000 people in primary prevention, it said that in primary prevention patients, if you give dapagliflozin, you can have less hospitalization for heart failure. Now, this part is brand new because we didn't even know that primary prevention patients would get heart failure. Like if I said primary prevention patient, Obama, no heart attack, no stroke, you would say, how does he get heart failure? It's not possible. And yet here we have a study that says we can reduce the heart failure hospitalization in that group of people. So not only is it occurring, these drugs can now pull them back and avoid them from developing the hospitalization for heart failure. So all of a sudden now, if I look at this spectrum, now I can say for the primary prevention, the only one that has data is dapagliflozin, right? So Farxiga is the only one that studied primary prevention patients and showed a benefit. So if you're dealing with a patient in primary prevention, then I would say that's the drug that you use. So of all the SGLT2s, and there'll be more coming out, this is the one that has data that's sitting around. In heart failure, like the old Obama, there is 2. So empagliflozin also did their heart failure trials, also had good results. So now we have 2 drugs to choose from, and so which drug would we choose? So to make sure that I'm not biased, right, what I'm gonna do is I'm gonna show you the data with no names, okay? So no drug names, no study names, and all you're gonna do is look at the data. So this way we become, agnostic to who is sponsoring the study. So let me show you the results. So which one would you choose, okay? So here are the outcomes. And so here's the results of the first study, okay? And this is what the results were. And here's the results of the second study. Those are the results that you see. So if you had to pick this for your mother, which one would you pick? So how many people would say the first one at the top? I got a few hands, okay? And how many people would say I'd pick the one at the bottom? And then the rest of you don't care. Yes, I understand that. Yeah, that's right. So how do we look at it? Let's look at the data, right? And so here I'm going to look at this particular cardiovascular death. So for the top one, you could see that the line doesn't touch 1. So therefore, there is cardiovascular death benefit. The second one, the line goes across, which means there is no cardiovascular death benefit. Okay? So if you had to pick it for your mother, I would pick it for the one with the cardiovascular death benefit. If I was picking for my mother-in-law, okay, that would be, yeah, then I don't care, right? One of the doctors last time shouted out, nothing, she deserves nothing, no treatment, anyway. So now I'll show you the name, okay? So in other words, we did this fair, right? So you didn't know which company sponsored what or whatever. So the one down here is empagliflozin, that touches the line, and then the one at the top is dapagliflozin, that touches the line. And the reason why I show you this is because it's too easy for us to say class effect. And it is true, there is a class effect, but there's differences amongst classmates. So think back to medical school, right? There was smart people, and then there was me. Okay, we're all in the same class, but then I was way down here. And so therefore, there are differences in classmates. And when there's a death difference, we have to pay attention to that one. We can't ignore those ones. So therefore, do I make a decision between DAPA and EMPA in heart failure patients? I go with the one with death benefit. So therefore, it's dapagliflozin. So that means that dapagliflozin for heart failure, you can use right across the spectrum, from primary prevention across to secondary prevention. And that's what we want. We want drugs that are simple. And therefore, like statins, we can use it across. ACE inhibitors, we can use it across. So this is what we're looking for, is do we have data that says I can use this early, and then I can protect these people as well. You've heard about the DELIVER study. So the DELIVER study was looking at preserved ejection fraction heart failure. So these are people where the heart can pump. So pumping the blood is not a problem, but the muscle is stiff. So it doesn't accept the right amount of blood. So if it doesn't accept the right amount of blood, even though it can pump it out, it's still not enough. So the rest of the body still thinks you're in heart failure, and therefore you're going to still have the symptoms. So again, diabetes, no diabetes. And let's go see what happens. You can see the results here. Very straightforward. Dapagliflozin, 10 milligrams, 18% reduction. Absolute risk reduction, 3.1%. Number needed to treat is 32. So again, fairly low numbers. And just to remind you, in preserved ejection fraction, we have no treatments that are approved. In other words, ACE inhibitors didn't work, beta blockers didn't work, MRAs didn't work, none of them worked. And so that's why the cardiologists are very happy that we see this separation for SGLT2 inhibitors. And the empagliflozin molecule has the same study and almost identical in terms of the results that we're seeing here. So if we were to put this together, we now have DAPA-HF, which is the reduced ejection fraction, and we now have DELIVER, which is preserved ejection fraction. So now we're going across the whole range of ejection fractions. So if we were to put it together, we can actually see what happens to these medications. So if we were to put it together this way, we put the two studies together, they took the data from both and they put them side by side, and they looked for ejection fraction going all the way across. And they looked for cardiovascular death or heart failure hospitalization. That was common outcomes for all of the studies. And what they found is that if it's below the line, it's good. If it's above the line, it's bad. So in this case, it's all below the line. And the reason why this line is special is you'll notice that the low ejection fraction, there is benefit. In the medium ejection fraction, there is benefit. And in the high ejection fraction, there is still benefit. So it's going across the full spectrum. And I think many of you are saying, okay, Peter, what's the big deal? All of our drugs go across the full spectrum, right? ARBs, ACE inhibitors. Let's go take a look at that. So let's look at the other drugs that we have for heart failure. And why is it that we don't have drugs for preserved ejection fraction? If you look at the ARB, you could see that at low ejection fraction, there is a measurable difference. The arrow is big. At the high ejection fraction, that arrow you can't even see. And so therefore, as your ejection fraction gets better and better, these drugs do not work anymore. And you could see that the line slopes upward. So in other words, the benefit becomes smaller and smaller, and that's why we don't have an approved drug for preserved ejection fraction people. And you're probably thinking, that's just ARB, what about MRAs and stuff? So here's ARNIs, here's MRA, here's digitalis. They all slope upward, meaning that as your ejection fraction gets better, there's no more benefit of the medication. And in the past, we were okay with that because we said, at least you have benefit for the low ejection fraction people. What about empagliflozin? That's an SGLT2 inhibitor as well. So is it flat or is it like this? And sadly, it is also sloping upwards as well. So in other words, as the ejection fraction gets better, the drug is no longer as useful. So therefore, dapagliflozin, in a weird way, has this strange flat line going across. And so what does that mean to you and I? It means that for dapagliflozin, if you use it in reduced ejection fraction people, there is benefit. If you use it in preserved ejection fraction people, there is benefit. And in the DECLARE study, those normal people that we talked about, the normal Obamas, it is also beneficial in those people because the primary prevention in that group had less heart failure hospitalization. So there is something different about these molecules that we're talking about, and we need to understand these differences so that we can bring the benefits to our patients. What about kidneys? This is the best nephrology slide that I have, right? Blood goes in and then pee comes out. This is nephrology all summarized into one slide. I love it. And the number of complicated things in there, and that's why we're not nephrologists. So for our panel members up here, the reason why none of us went into nephrology, because none of us understand acid base or any of those crazy things that you guys do all day long. Once the kidney fails, then you lose a lot of things. You can no longer produce bicarb, you've got acidosis, you can't regulate any of your salts or anything. Potassium becomes a disaster. So that's why we want to preserve kidney function as best we can. So what about kidneys and SGLT2? Initially, we thought that the SGLT2 inhibitors would be bad for kidneys, right? Because you're going to increase the sugar going into your kidneys and sending it out. And so people were worried that you're going to have problems. But there were these genetic people that had missing SGLT2. And they always had sugar in their pee for their whole life. And their kidney function was fine. So where does the kidney get damaged from sugar? And let me just show you how that is. So if we were to look at the kidney spectrum, again, you have CKD at some point, then it's secondary prevention. We're trying to prevent you from going on to dialysis. And so that would be the old Obama, right? And then primary prevention would be the young Obama. In the old Obama situation, kidney disease, you have no symptoms until the very end. So he will have no symptoms at all, even though his eGFR is 40 and his albumin-creatinine ratio is 30. So he's spilling protein. So think of the eGFR as the speed of the filter, and then think about the albumin-creatinine ratio as the quality of the filtration. In other words, is it a good filter? So a good filter keeps good things in and gets rid of garbage. So good things is protein, and we've decided to measure albumin. So we should be keeping albumin in and just getting rid of creatinine, which is breakdown of muscle, so that's garbage. So if your albumin-creatinine ratio goes up, you're losing more good stuff, and therefore a high ACR is not good. So that's one way to explain to your patients, eGFR is speed, and albumin-creatinine ratio is the quality of your filter, and that way they know that they have to do both tests to figure out what their kidney function is like. So let's look at this picture, and you've seen this picture millions of times in SGLT2 talks, so I'm going to take it through a little bit differently. So here's the filter, right? Blood goes in, goes through the filter, blood goes out. And then the right side is all your urine that you're producing. There's two things in diabetic kidney disease that causes damage to the kidney. The first one is the glucose sticking in the filter. So in the blood vessels, there are proteins. Glucose will stick to that. That sticking process is known as glycosylation. When sugar glycosylates to a protein, it makes the protein change, and therefore you get weak blood vessels and you get clogging of the blood vessels. That's the exact same thing that happens in the eye and in your microcirculation in your heart and in your feet. So that's why we measure sugar sticking to your blood, because that's the same process. That's why we call it glycosylated hemoglobin. So the sugar sticking in your eye and in your kidney is the same sugar sticking to your blood. And that's why we measure an A1C as a marker of damage. So anything that lowers sugar will help with that. Insulin, SUs, DPP4, all of them will help with that kind of kidney disease. The second kidney disease that you have in diabetes is hypertension. So it's too much pressure inside that filter. So that filter runs at half systolic. So if your systolic pressure is 120, the filter pressure is 60. And that makes sense, right? You have to take garbage away, so you don't want the blood flow too fast. You need time to take the garbage away. So therefore, the filter pressure should be half systolic. If accidentally you let in more pressure into that filter, you're going to kill the filter, okay? So the second problem is hypertension in the filter, and the SGLT2 is very good at fixing that. So let me show you how that goes. So blood comes in, goes through the system and out. Glucose is a very small molecule, and so the filter cannot stop it. So all the glucose ends up in your urine over here, okay? That's happening right now in your body. All the sugar is going. But we need the sugar as our fuel source. So therefore what we do is we're going to give you a pump to pump it back. So the sodium glucose cotransporter, SGLT1, SGLT2 pumps will bring back the glucose. but it's a sodium glucose co-transporter, which means for every glucose you bring in, you have to bring in a sodium. And that's fine. Everything's in balance. In a patient with diabetes, there's a lot of sugar in the blood, so therefore there's a lot of sugar ending up in the urine. And so now this pump is going crazy, thinking you need all that glucose back, so therefore it's pulling back a lot of glucose, which also means it's pulling back a lot of sodium. And that's where the problem comes in. Because what happens when you pull out all the sodium from the urine sodium drops. Now the reason why that's important is there's a little police officer monitoring the urine sodium. And when the urine sodium drops, he's using that to decide, are you making enough urine? So if the sodium drops, it thinks that you're not making enough urine. And what's the most common reason of not making enough urine? It's just not enough blood flow going into the kidney. And so therefore, what's he going to do when he sees the sodium drop? He's going to call ahead and say, please open the pipe up to let more blood flow in so that you can make more urine. At the same time, another mechanism will tell the out pipe to squeeze tight, so therefore, again, you can make more urine. There's the problem. We just let in more pressure into the filter. Now, in a person with diabetes, they always have high sugar. So therefore, this system is there all the time. High sugar, you pull out the sodium, low sodium, the pipe is now always big in this situation. So now what we have is the pipe is too big coming in, and we've now set up diabetic kidney disease. So let me just show it to you in a much more simple version. This is a normal kidney, and this is your diabetic kidney. I just explained why the pipe coming in is too big, and I explained why the pipe going out is too small. And so basically now what you've got is you've got Sri Lanka traffic, right? You know, going inside there. Too many cars, right? Too many cars going in, can't get out. So now we have high pressure building up inside the filter. So if I put high pressure on a filter, what will happen is you'll hyperfiltrate, right? So initially when you measure diabetic kidney disease, you'll see the eGFR is actually high. So you'll see a height, like 130, 140. That's a bad sign because it means there's a huge pressure pushing on the filter itself. If you push hard enough, you're going to squeeze protein out. So that's why we see proteinuria early in diabetic kidney disease. So that's why measuring the albumin-creatinine ratio is so useful in diabetic kidney disease. Over time, as the pressure continues, the renal cells die, and then your eGFR starts to fall. Now the filtering speed is going to go down. So what do we give to all our patients? Before SGLT2s, what do you give to all your patients with kidney disease? What drug do you give them? Yeah, ACE inhibitor. I can see everyone. Yeah, ACE inhibitors in ARB. And which pipe does it work on, the in pipe or the out pipe? In pipe or out pipe? How many people say in pipe? How many people say out pipe? Okay, good. Out pipe wins. I like these half hands. You know, people look around. They do these half hands, right? And they look at the senior people. Are they putting up their hand? No, and then put it down. So basically, the ACE and ARBs will work on the out pipe by making it bigger. So by making it bigger, you're going to drop the pressure, and therefore, it'll protect the kidney in the long run. What happens when you drop the pressure? Your filtering speed slows down. So the eGFR comes down a little bit, and that used to freak us out, right? And then the nephrologist says, don't worry, up to 20% is okay, because you're lowering the pressure. Yes, the filtering speed will slow down a bit, but in the long run, you're protecting the kidneys. So that's why they said it's okay. However, the in pipe is still too big. So therefore, you still have too much pressure. Now, who's keeping that pipe big? It's the police officer. And all he wants to do is see sodium. So if I give you an SGLT2 inhibitor and I block the pump, now the sugar doesn't come out, which means the sodium doesn't come out, which now means the pipe can now go back to normal. So the police officer will say, turn it back to normal. Notice it doesn't vasoconstrict it. Vasoconstriction causes acute kidney injury. So NSAIDs vasoconstrict. This one is just bringing it back to normal, okay? So now, with normal pressure, you have normal filtration, less proteinuria, and hopefully the renal cells will last longer. Now, can I show you this in real terms? And so this is the eGFR on one side. This is going across 4 years of time, and I want you to follow the black line. So the black line is just giving the ACE or ARB, so just opening the out pipe, but the in pipe is still too big. So you could see that it continues to deteriorate, okay, because the pipe is still too big. Now, don't get me wrong. Without the ACE inhibitor, it would be even sharper going down. So the ACE inhibitor is helping, but it can't correct the in pipe. If I give you the SGLT2 inhibitor and I tell the police officer to close the in pipe, you could see the eGFR is much more stable. It's still going down, but not as much. And so this is the incremental difference that the nephrologists have been looking for all this time. So up until now, we've had no incremental benefit beyond RAS inhibition. So now on top of RAS inhibition, by controlling the in-pipe, we can now have these benefits. And you could see that patient number 2 on SGLT2 is less likely to end up in dialysis because the eGFR is not going to fall as fast. So perhaps we can push off dialysis as well. In the DAPA-CKD study, the big deal there was they started off with people all the way down to eGFR of 25. So initially we said eGFR below 45, don't use SGLT2 inhibitors, and that's because it no longer gets rid of sugar. So below 45, you're not getting rid of sugar, so the A1C doesn't come down enough for it to be a diabetes drug. So that's why the government said below 45, don't use it, because it's no longer a diabetes drug. We don't really care about the sugar anymore. We care about the pipes. And so therefore now with these types of studies going down low, we can now correct the pipes and perhaps we have benefit. And what we see here is all the outcomes on this side. The first one is renal and cardiovascular death outcomes, and then the rest of them are components of it. And I'll point it out to you that basically the cardiovascular death, or total death I should say, is reduced by 31%. So people on dapagliflozin were less likely to die in terms of if they had kidney disease. And of course, this is diabetes and no diabetes. So in other words, non-diabetic kidney disease was included as well, okay? So therefore, it's nothing to do with sugar, it's more to do with the sodium management. Now you're gonna ask me, hold on, what about the non-diabetes? How does that work, okay? So I had to think a lot about this because nobody's written a paper. Usually I read, I copy somebody else, I learn how to tell a nice story. But this one, nobody has written a paper on this, so I had to make it up. So this is all fake news that I'm gonna tell you right now, okay? So here is how it works in non-diabetes kidneys. So we have about 1 million of these nephrons sitting there inside our kidneys. And so let's say you have glomerulonephritis, IgA nephropathy, and you wipe out half of them. So half of them are gone. What is going to happen to your blood flow? Because your body needs to send the blood to your kidneys, but you don't have as many workers. So what are you going to do? So let's say half of you have COVID, then the other half is going to be working harder, right? Like they're going to send all the patients to you. So how do we send all the patients to the kidney? Well, we open the pipe. And by opening the pipe, we can now send the blood flow to that filter, but now we've increased the pressure in the filter. So that's what your body will do, is open the pipe and then let the blood come in. So we've just created the same problem that we talked about just now. The pipe is too big coming in. Now, if the pipe is too big, who's doing that? It's not the police officer this time, because your urine sodium is normal. No problem with your urine sodium at all. So this pipe is being opened by sympathetic tone. So your sympathetic parasympathetic tone is opening this up and letting the blood flow. And we don't know how to stop that. I don't know how to close that pipe down for these patients. However, I do know how to talk to our police officer. If I give him an SGLT2 inhibitor, I'm going to increase the amount of urine sodium, right? Even in a normal person, if I give it to you, I'm going to increase the sodium in your urine. And when that police officer sees too much sodium, what's he going to do? He's going to call back and he says, shut the pipe down, you're making too much urine. So we actually trick the police officer to closing down the pipe, therefore reducing the pressure back to normal, and therefore protecting the kidney in the long run. And it's because we don't know how to talk to the other system, we borrow our police officer and we know how to talk to it. And that's how it works in non-diabetic kidney disease. Make sense? So, what about young Obama? So with old Obama, I know what to do. What about young Obama? No symptoms again, and let's say his GFR is normal, 85, and let's say his albumin-creatinine ratio is 2, so that's normal. So in the DECLARE study, by accident, the FDA said you must enroll people with eGFR above 60. That part wasn't by accident. That part was them saying, the other studies looked at sick kidneys, we want you to look at healthy kidneys. And when they finished the enrollment, the average eGFR was 85. So in other words, pretty good-looking kidneys. We're not allowed to do a study on normal people, right? You're not allowed to say, I want to give you a drug and see what happens to normal people. But accidentally, we have a collection of normal kidneys, and we could see what happens when they're on an SGLT2 inhibitor. These are the renal outcomes. So eGFR has to go 40% down, and you have to go below 60. So that's a pretty big drop. You have to have dialysis, or you have to die from kidneys to be counted as a renal outcome. So what did they see? So first of all, let me set it up. Placebo group, the pipe is too big coming in, and the outpipe is too small. The dapagliflozin group, the pipes have been corrected. So imagine 4 years of the study, pipe not corrected versus pipe corrected, there will be a difference. And that's what we're seeing here, a 47% reduction in that renal outcome, mainly driven by the drop in the eGFR. So basically what this is saying is that in people on dapagliflozin, the pipes were corrected, so their kidney function stayed good. In the people with the pipes not corrected, their kidney functions decline, and that's why you have this big differential 4 years later. So what this is telling us for dapagliflozin is that in good eGFR, you can protect those kidneys by correcting the piping, okay? So that means we can start these things earlier. Now recently, the KDICO, the kidney folks, you know, that do the global guidelines, they came out with a diabetes chronic kidney management. Not all kidney, but just diabetes specifically kidney management. And there's a lot of stuff on there, okay? I'm not gonna go through all that stuff. You know it about statins and all those other things. I just wanna show one spot here. First-line drug therapy, SGLT2 inhibitors, all the way down to eGFR of 20. So the EMPA kidney study went down to 20 eGFR, so now they're saying all SGLT2s are safe to go down to those levels, and you keep them on it until dialysis. In the study, once they hit dialysis, we took them off the drug. So therefore, that gives us quite a latitude to be able to use these medications for our patients. For all kidney patients, that will be coming. So those guidelines are being reviewed right now. And I showed you the non-diabetic kidney disease, people did well. So you're gonna see something kind of similar saying that it should be probably first line for them as well. But those guidelines will be coming early next year, okay? So dapagliflozin for the primary prevention Obama, we know that data is there, no problem. What about the old Obama? We actually have 3 studies in kidney disease in old Obama with 3 SGLT2s. I'm going to ignore canagliflozin because it only did diabetes. It didn't do non-diabetic kidney disease. So I'm going to ignore that one because it was only diabetic kidney disease. So I'm just going to look at DAPA and EMPA. Which one should you choose? And I'm going to do the same thing. I'm going to take out the names so you don't know what I'm just going to show you the data. So here's the outcomes that we're looking for. And you know how to play this game now, right? So here's the first study, and here's the results. And here's the second study, and here's the second results. So how many people would choose? We'll do it for your mother-in-law this time. No, just kidding. It's terrible, right? So if my mother-in-law ever sees this, it's bad. So how many people would choose the top one for your mother? Okay, good. And then how many people would choose the bottom one for your mother? Okay, so you know how to play the game already, right? So you know what you're looking for. In this case, it's all-cause mortality. The top one is significant benefit. The bottom one, it crosses. So every time you see this slide in the future and you have a speaker that says it's class effect, it is true, class effect, but there's differences between the classmates. And so this one is empagliflozin from the EMPA kidney, and this one is dapagliflozin from DAPA-CKD, okay? So again, the decision point over here is you choose the one with death outcome, so therefore it would be no question as to which one you use. So for kidney disease, you can use across the spectrum as well, okay? What if he was on a DPP-4 inhibitor? Should you leave him or switch him? We have a lot of people on DPP-4. It's a very safe drug. It's easy to use. So we need a head-to-head study. So this is my head-to-head study. It's very hard to do a head-to-head study. So what they did was they looked at real-world data, CVD Real Nordic. They had 1 million people with diabetes, and they matched 30,000 people taking DPP-4 to 10,000 people taking dapagliflozin. And remember, these are not they're not kidney disease patients. They're just diabetes patients that were put on one drug or the other. And they matched them up for age and everything else. It's 30,000 on this side because there's 3 good DPP-4s. So therefore, they gave them each an opportunity to try and win. And so here's the first bit of data that came out. And I was very excited when I saw HKD. I thought that meant Hong Kong dollar, but it doesn't mean Hong Kong dollar. It means a hospitalization for kidney disease. So 62% less hospitalization for kidney disease for the SGLT2 side against the DPP-4 side. And these are not kidney patients, but that correction of stuff was happening. So I'm just explaining it to you now, but it's been happening for the last 10 years, ever since we've had these drugs available to treat patients. What about for heart failure, MACE, death, those kinds of things? And so you see the MACE outcome, which is heart attack, stroke, and cardiovascular death, reduced by 21% in favor of dapagliflozin. Heart failure hospitalization, 38% reduction, and all-cause mortality, 41%. Okay, so when people say, well, we're not sure, we'll keep them on the DPP-4, we are sure that we should be on the one side because you'll have more benefit for them. And I love this picture that I always use to represent things. So remember how I used to carry all that stuff? Now, some of you are very young, so you don't even know what a pager looks like, right? But you don't carry any of that stuff now, right? All you carry is this little thing, right? That's all you do. This thing is so important to you that if you left this at home, you'll go home and get it, right? You'll go home and get it. If you left your child at home, you will not go home and get your child, okay, right? Am I right? Okay, yeah. So the value, this is the importance. And the reason is this thing does all of those things, right? So it's important, it does all those things. So in a weird way, the SGLT2s have become the smartphone, right? So it lowers A1C, blood pressure, and weight. We weren't interested in that, but cardiovascular death, heart failure, hospitalization, kidney benefits, now we're paying attention. And as you'll see, our panelists, every division is paying attention to this. And then I was thinking, what about DPP-4? What should DPP-4 be like, right? And so I saw the taxi driver that was driving me, he had an old Nokia. Remember the old Nokia cell phone, right? The one you throw it on the ground, it explodes. And I said, why do you have a Nokia? He goes, it's very good for phone calls, and the battery lasts forever. So it's good for one task. So what is DPP-4 really, really good for? Out of this whole list of stuff, what is it good for? It's not renal benefits, not heart failure, not CV death, not weight, not blood pressure. It's very good for A1C. So that's why you're going to hear people saying, give them the package, and then if you need a Nokia, then you can get a Nokia afterwards, but not the other way around. And what about SU? I was wondering what should represent SU, right? Okay, so this is the old way. Yes, I know it's cheap, but you lose A1C control, there's hypoglycemia, there's weight gain, there's potentially cardiovascular death increase when you look at millions of people. If you look at 7,000 people, no difference, but if you look at millions of people, there's an increase in cardiovascular death for SU. So let's move away from the SUs that we're looking at. So that's why most of the guidelines, metformin and SGLT2 seems to be the way to go, and then DPP-4 or GLP-1. GLP-1, the problem is it's too expensive and it's injectable and so on and so forth. So those are the combinations that you're looking at. And if you look at this, I made up this table in terms of which drug should I use. So if you look at the MACE outcome, do they have any MACE outcome? Metformin has heart attack reduction in UK PDS, and then it's SGLT2 and GLP-1. For heart failure, really the only one is SGLT2. The GLP-1s are trying, but they have to put all their studies together and say, look, there's a 9% benefit. Whereas SGLT2, every study, there's a heart failure benefit. Kidney disease, clearly it's the SGLT2. So you can understand why the SGLT2 inhibitors have become the darlings of all the guidelines, cardiology, endocrinology, nephrology guidelines as well. And you can understand why a combination with metformin seems to be a good idea, SGLT2 combination as well. So if I were to summarize the dapagliflozin data, and I like that one because it includes primary prevention patients, then we would say for heart failure hospitalization, I'm going to break it up into secondary and primary patients. What do I mean by secondary? Secondary are patients that had a heart attack, stroke, kidney disease, or heart failure. They're sick already, and there's good data there. Primary prevention means they haven't had anything. That's the young Obama, and they have data sitting there. You look at kidney disease, same thing. Sick people, old Obama, young Obama. And then the big one is all-cause death. So in all-cause death, heart failure, it had benefit. That's the one where I showed you the data without the names. And in kidney disease, they have all-cause death as well. So that's why going across the board, it's actually quite good in terms of the profile. And where is it different than the other SGLT2 inhibitors? It's in the primary prevention, because the other SGLT2 inhibitors did not enroll people with primary prevention and couldn't show a benefit there. And the other area that's different is this all-cause death. As I showed you with the two comparator, this one has all-cause death in both sections. So if you're going to look at medication, dapagliflozin can go across both primary and secondary. Oh, this is a good one. Eh? I was told this is a famous dish here, right? So now imagine if I was to make this dish, okay, versus the original, let's say you guys making it. I would not know the ingredients, I would not know the spices and the proportions, and I would have bad experience for quality control. So this is where we get into generic versus non-generic. And I don't want you to think that, oh, because this is a symposium, blah, 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 he's going to say that generic is no good. We all thought generic is good as long as you follow the same recipe. So originally, the generics were following the same recipe, which means the same ingredients and everything else. Okay, and that's fine. In this case, it's not. So for dapagliflozin, there's two versions of dapagliflozin. So Forxiga uses the crystalline dapagliflozin, but because that patent is owned, the generic one has to use the amorphous dapagliflozin. Amorphous means not crystal, so loose, kind of liquidy. And it says that amorphous dapagliflozin is not stable, and it degrades, and you can have lower efficacy from that. And so these are the concerns that we have when they don't use the same formula in terms of making it. The reason why I know this is because they all have to file patents. So these generic companies have to file a patent on their molecule that they're going to use. So let me show you one of those patents and what it says. So this is solid forms of amorphous dapagliflozin. That's kind of crazy, right? Amorphous is not solid. How do they make it solid? Well, we stabilize it with one of these polymers, copolymers, saccharides, in order for us to be able to use it. So in other words, they take the amorphous and then they have to stabilize it and then they can work on it. So that's in their patent because they have to say, why is it different than the original dapagliflozin? Otherwise, you can't get a patent. The other problem is left hand, right hand. Okay, so left hand and right hand, there's a left hand molecule and a right hand molecule. So these are the R and S versions of things. So for example, would be a left hand molecule. You can see the hydrogen is on the thumb, and this would be a right hand molecule. And it turns out receptors and enzymes like one version better than the other. So one version fits better than the other. So in the case of dapagliflozin, how many positions could you have a left or right hand version? And you see those red dots, all 5 of those, you can flip it as left or right hand. Now that's a problem. Unless you get the combination right, that molecule isn't going to fit properly. And if it doesn't fit properly, then you don't know about bioavailability, how does it work, and so on and so forth. And if you don't know what happens there, then you have no idea what the clinical outcome will be. Are you going to get the same results that we have? So back to this picture of the food, you can understand that if I don't use the same fish, I don't use the same spices, and I have no experience, that's a problem. And that's why we're having some difficulties with people not being controlled. Now, you're probably thinking, can you show me some outcome data? And right now, not for this, because this class is new, right? You're starting to use the generics recently, and we're not tracking. But statins, we've been tracking brand versus generic. And we have a lot of data on that one. So here is in Spain, they tracked 13,000 people in their database, original versus generic versions of statin. And they looked at cardiovascular events, not just LDL control, but cardiovascular events. And you can see that the cardiovascular events is increased in the generic side of the equation by about 31%. If you look at people that had an event already, so you had an event and now they're looking for all-cause death, so this is death rate now, you could see that there is an increase in the statin that were the generic version versus the original by 62%. You and I won't see this in individual patient. So if the patient dies, you're not going to say, oh, it's because of the generic statin. If the patient has a heart attack, you're not going to say it's a generic statin. You won't see it. It's only when they look at government databases that they start seeing these patterns emerge. So I show you this because I just explained they don't use the same ingredients, which now means it's not going to be the same. So therefore, I know everybody always tells me, but Peter, it's the cost, right? And I agree, it's the cost. You know, cost of medication is crazy. So I had to come up with some way to think about cost. So I thought about coffee, okay? So around the world, a lot of people drink coffee. So here I was told that a normal cup of coffee is 300 rupees, roughly, right? And then you have the fancy brand, which is the Java, right? The Java coffee, right? That's the good one. And that's 750 rupees, right? So people are buying these kinds of 1 cup of coffee a day. And let's go with the 300 rupees as the normal for people. And so what is the cost of Farxiga? Anybody know? Is it more than 1 cup of coffee? Is it a Java coffee? Or is it less than 1 cup of coffee? Like, what do you think is per day? Any idea? So it's this way. So it's 205 rupees. Okay? And for 205 rupees, so less than 1 normal coffee a day, less than 1 cup of a day, you get all that stuff. I know the coffee makes you feel good and happy, but this one would give you all of these things as well. So when we talk about cost, let's just make sure that we can explain this properly. So if the person is drinking a coffee, then for the same price as the coffee, they will get these kinds of protection. So therefore, do we need to go to an SU or things like that? The answer is no. What about generic DAPA? So if the original is less than 1 cup of coffee, then the difference is only 145 rupees, which is less than half a cup of coffee differential between original and the generic. But the generic may not work. So now for the price of half a coffee, we're willing to take a risk. And that would be like me saying, in your car, I'll give you a part that may not work, and we'll put it inside your car. And I think any one of us would be able to do that. So therefore, the cost differential is quite low. And so I want to make sure that the people get the right benefit, because our goal is to make sure they don't get heart failure, they don't get kidney disease, they don't have these complications. So on the Farxiga side, the crystalline dapagliflozin, you've got all these studies. On the generic dapagliflozin, or generic empagliflozin, or generic whatever, they have 0 studies. They don't have to do the trials. And so therefore, we don't know if they work. My final one, this is a label from clothing that I had, and it said this, remove child before washing. Okay, so I never thought I'd have to show you a label, it looks like, which means some child was in the clothing when they washed the kid. Anyway, so maybe that's how you wash the kid and your clothes at the same time. So to make it very simple, what is my message? I spent a long time, I apologize. Prevention to treatment, it would be nice to use the same medication. And that's what we have for ACE inhibitors, that's what we have for statin therapy, and now the SGLT2 inhibitor, it looks like with dapagliflozin, we can go across that same spectrum again. So we could prevent disease and we can treat the same disease at the same time. And our goal is to not have a lot of heart failure patients and kidney failure patients and so on and so forth. And really that's the goal of doing all of these studies and everything else. So now what we're gonna do is, after all this silly talk, we're gonna have our panel, I think, and this is where we get into the really useful information. And the folks that you have up here are the top. We're joking that they were senior, and everybody had a problem with the word senior because it makes it feel old. So we said top in the field. So these are the top in the field. And I'm really privileged to share the podium with all of these expert panels that we're gonna have coming up just next. Anyway, thank you very much for your time.
A big thank you to Professor Peter Ling, Dr. Peter Ling, for that excellent lecture. Can we now get on with our panel discussion? Can I also invite Dr. Peter Ling to be on stage with us? And may I now invite our panelists, Dr. Chandrike Ponnamperuma, consultant cardiologist, president of Sri Lanka College of Cardiologists, onto the stage. Dr. Sanjay Kalra, president of SAFIS, to be on stage. Dr. Chula Herath, consultant nephrologist. Dr. Rakesh Sai, consultant endocrinologist from India. Professor Prasad, Katulanda, consultant endocrinologist. Dr. Uditha Bulugahapitiya, consultant endocrinologist. Dr. Sanjeewa Rajapakse, consultant cardiologist. Dr. Tilaka, consultant endocrinologist. And our moderators today are Dr. Tharanga, Samarasekara, consultant endocrinologist, and Dr. Dimuthu Muthukuda, consultant endocrinologist. Please come to the stage to start the panel discussion. Thank you. Tharanga to start the discussions.
So once again, thank you very much, Professor Peter Ling. So that was quite very interesting. And, but I feel really sorry for the poor Barack Obama, the young Obama and the elderly Obama. And also you spoke about our delicacies like ambultial and the Sri Lankan coffees. It's quite impressive. I don't think that anybody will be able to, simplify this talk further. So it's very impressive. Thank you very much. So let's get on with the panel discussion.
So let's start the mesh today. So the first question is for Dr. Manilka. So now we have all this trial evidence, but as a practicing clinician, practicing endocrinologist is a basic practice. So how are we going to make the individual decision to start an SGLT2 in a patient? What is your take on that, sir?
Well, first of all, thank you very much, Peter, again, for simplifying this. So when it comes to Sri Lanka, I think this is your first visit here, and the subcontinent. The cost matters a lot. And people who go to the Java lounge will be like only 5 to 10% of the population. Sometimes when we work in the periphery and all that, they may not even have a coffee a day. So that sort of a population is also there. So, but when you look at the overall, so we have the cross-section, affordable people, and all levels. So when the SGLT2 inhibitors first came into Sri Lanka, what we went for is for the higher end of the, the upper, higher economic background. And so it was fourth line agent. And then we realized when more and more studies were coming in and the indications, and our cardiology friends and the nephrology friends are nowhere in the scene at that time, we were prescribing for glycemic control. And then it went up the ladder as and when, as you said, the DPP-4 inhibitors, the efficacy, and then the heart failure studies coming in. So it almost became second line for people who this thing. And we love our metformin because it's the high level of insulin resistance in this part of the world. Sanjay also might comment. So then we had to look at the real world data, the side effects. Because we had the apprehension our people will work in the fields, higher temperatures, humidity, the element of dehydration would be more in our people compared to the studies done elsewhere in temperate climate. So all these were our concerns. And the common side effects of the urinary tract infections and the genitourinary fungal infections, we were wondering because of the humidity, high humidity, 90%, certain people, whether that would be high in our part of the world. I think we have data from India we can discuss. So I think, so it has really come up the ladder, and then our nephrologists and the cardiologists are prescribing them in large numbers. So it's really going up the ladder, but we need to have a sort of a more inclusive look at the molecule in terms of how it can be adapted to our part of the world. Cost, number one, then its side effects, the potential hyperglycemic or the euglycemic ketoacidosis, which we will discuss later, and the real world data on the side effects compared to the Western data. And of course, the local heart failure and CKD, whether there are any other compounding factors, we'll have to see. So it's very interesting times. And what you showed is really, really useful. We need to adapt this to the country and the subcontinent. I think that's what I feel.
Thank you, Manilka, so that your answer sets the stage for the rest of the discussion. So the next question goes to Dr. Uditha Bulugahapitiya. Uditha, would like to tell us about the glucose-lowering effects of SGLT2 inhibitors.
Yeah, now when you look at the glucose-lowering effect, especially in terms of HbA1c, if you use the SGLT2 inhibitors as a monotherapy, reduction is like 0.5 to 1%. That is moderate control. Now, if you that's on its own, actually, when you combine with others, that can be different. And at the same time, if you compare with metformin, like it's 1 to 1.5 reduction of HbA1c, and sulfonylureas, again 1 to 1.5, glitazones 1 to 1.5, DPP-4 inhibitors 0.5 to 1, GLP-1 analogs like 1 to 1.5 again. So it's about moderate control, I feel, when you compare with other medications.
And also, Uditha, so when we are starting SGLT2 inhibitors in our patients, so what kind of problems would you anticipate?
Yeah, actually, when we are starting, I think most important thing is that we can start the SGLT2 inhibitor in the whole spectrum of the disease, because beta cell function is not necessary for the SGLT2 inhibitor action because it's not insulin dependent. Therefore, all the spectrum you can use it. At the same time, you can combine it with any of the other medications that is available for the clinical practice. And I think when you use, you have to be careful about the side effects, as Dr. Manilka said. The commonest are like polyuria, then urinary tract infections, and euglycemic ketoacidosis and things. Others are extremely rare. And therefore, in our setting, I think we have to correctly advise the patients, like take at least 8 glasses of water, then wash after urination. And also, if the patient is fasting, and if the patient is going for acute illness or any surgery, then to try and stop that. And also, I think when you are starting, you have to decide if the patient has got some bladder stasis, like prostate enlargement, like something to increase the urinary tract infections, like renal stones and things. You have to be a bit careful because it can cause more urinary tract infections if that happens.
Uditha, any particular timing of the day that you would like your patients to take the SGLT2 inhibitors, like morning, evening, so how, what?
Yeah, actually there is, because if you give it tonight, people say that you have more polyuria, but I think when you compare the clinical practice, there is no major difference. So I think first is the patient's preference. If not, I think it's the morning is better.
Can I just add to that? So in the studies, they measured how many times extra they peed. So it's 1 extra time per day. And just like diuretics, when we give diuretics, initially they have it, and then afterwards they're quite okay. And you're absolutely right. Both of you were mentioning about how to explain to patients, and I skipped that part because they said you have 40 minutes because we have excellent panel. So what I tell patients is that you have to drink water. So in a hot place, you have to drink water to stay hydrated. And what we need to do is by drinking water, you make the urine more dilute. So the amount of sugar in there is diluted by the amount that you're drinking in, and therefore the concentration goes down and your risk of a yeast infection goes down as well. So that's a very good way to explain to them that one. Urinary tract infection, if you look at placebo and the drug, it's the same. So there is no increase in urinary tract infection, but it's high in both groups. So in the study, the placebo group had almost 20% UTIs, and the treated group was about 20% UTIs. The big difference was the yeast infection. So if you get them to drink water, that will dilute the urine, and therefore they won't have as much problems. The one about the surgery, it's true. So if you're sick, I tell patients if you're vomiting diarrhea, these drugs get rid of water, salt, and sugar. That's what they do. So if you're vomiting or diarrhea, I need you to keep the water, salt, and sugar so you hold the drug. If you're going NPO for surgery, I need you to keep the water, salt, and sugar, so hold the drug. So if we say it like that, then they understand that I need to keep the water, salt, and sugar, that's why I stop the drug. Whereas if you say it, if you get sick, stop these drugs immediately, then they're afraid that these drugs are killing me, right? And all my patients think I'm killing them all the time. So anyway, so this would be another situation for them. And for the non-circumcised males, and I'm sorry I'm gonna go into some detail here, non-circumcised male, you have to tell them to pull back their foreskin to pee. Otherwise, there's a drop of urine that stays in the skin that has a lot of sugar content, and then you get the balanitis. So tell them to pull back foreskin to pee, and when they wash, they should wash and then dry. Now, one time, just as a funny, I told that to a patient. About a month later, the wife came and said, could you tell him he doesn't have to sit on the sofa for 1 hour drying? Like he was, you have to be specific.
Thank you, everyone. So one can argue, so the evidence we see is done in a different part of the world, but when it comes to South Asia, we have different climate, we eat different things, our body habits is different, and we have a mixed racial groups. So what is your take, Sir Professor Katulanda and Dr. Rakesh Sahai, when it comes to our part of the region, what is your experience?
Thank you, Tharanga. Actually, we actually looked at the data for about 2 years in about a group of patients, about 2,000 patients. So we have used mostly because the empagliflozin came to Sri Lanka first and few patients on DEPA as well. So we have got very good data on A1C reduction, and compared to most other drugs, the persistence of the reduction is quite impressive for about 2 years. And again, the weight reduction as well as maintenance, so that you don't see with other agents and even with lifestyle. So this is again very important. And the other thing is the blood pressure reduction. And we have classically seen this, the renal protection also, again, initial dip, and then subsequently the lines crossing with the group that is not taking and the group with the taking the SGLT2. So all these benefits we have nicely demonstrated. So we haven't looked at the cardiac outcomes in these patients, so I have to confess on that. But I would say we have seen that generics as well as the originals working quite, uniformly without a major issue in those aspects like the glycemia, the weight, blood pressure, and the renal outcomes. Since I haven't looked into the cardiac, I can't comment on that. The other thing is few other things with regards to the side effects, Tharanga. Again, in the non-circumcised males, balanitis is common. So another tip that I would like to give is, particularly before starting SGLT2 inhibitor, ask your patient whether he has ongoing balanitis. So if the patient is having ongoing balanitis, be very careful. Fair amount of patients with very high glycemia, they have balanitis, and some of them has phimosis. Again, particularly, I don't use SGLT2 inhibitor in a patient who get already phimosis with chronic fungal infections. So those sort of tips are important. And as well as the other thing is, since we advocate a lot of water intake, it might be useful for them to take in the morning, because if they take in the night and start drinking a lot of water, they will keep up. At the same time, what we see another phenomenon is that some patients find it difficult to tolerate the sort of hypotensive effect when they take in the daytime. So those people tolerate when they are taken at night. So those are the other tips that I would like to give from our own experience and the data. Thank you.
Dr. Rakesh Sahai.
So I think Dr. Prasad has highlighted the experience that he has noted in this part of the world, and even in India, we have been using these molecules for quite a few years now, and the experience has been and we have a few real-world studies which have looked at patient populations of about 500 to, I think the largest study has about 2,000 patients in that. And the experience has been that the reduction in HbA1c has been similar to what has been noted in the large phase 3 trials and also the CVOT trials. And but the improvement in with regard to the practice of prescribing that, the general practice is to prescribe it in the morning. That's the general practice in our part of the world, and I think the rates of infections, rates of genitourinary infections has been similar to what is reported in the other countries. And the other issue that I would like to highlight is that, as Dr. Prasad said, that we need to be vigilant about looking at certain points like pre-existing balanoposthitis and pre-existing phimosis. In such situations, probably we should be careful about prescribing this medication. But by and large, the experience has been very good, and the use has increased tremendously in the last 2 years since the DAPA has gone off patent. Although Dr. Peterlin has very nicely shown us that there could be differences between the generics and the originator brand, but the widespread use has happened after that. But although it was being used earlier also, so I think the experience has been good in our country with the use of these molecules, and the use has increased quite significantly in the last few years.
Thank you, Dr. Rakesh. That's a wonderful explanation. It's good to hear that we have positive results in this part of the world as well. Now I have to congratulate Dr. Dimuthu for getting the nephrologists and the cardiologists in our team on the same stage to discuss about the SGLT2 inhibitors, because we have been fighting why the cardiologist is using our drug. So, Dr. Sanjeewa, in which patient populations would you initiate an SGLT2 inhibitor from a cardiologist's point of view?
Yeah, from a cardiologist's point of view, actually, we have been using this molecule for quite a long time. To start with, in patients with heart failure, with reduced ejection fraction, so we didn't have any doubt. And also, actually, if you take the full spectrum of heart failure, and the patients who have had a mildly reduced or moderately reduced ejection fraction and features of heart failure, obviously, all the cardiologists would use it. With the current evidence or the recent evidence that this particular molecule, as Professor Lin initially mentioned, and this is the only molecule which has shown a significant reduction in deaths and heart failure, hospitalization in patients who have got a normal ejection fraction and clinical evidence of heart failure. So basically heart failure patients with preserved ejection fraction. So obviously we picked a molecule, this particular molecule, SGLT2 inhibitors, to treat them. So in summary, a full spectrum of heart failure, all the phenotypes of heart failure, there's no doubt that they are benefited with this particular molecule. And in addition, patients who have got acute heart failures, the new evidence is coming up, and we have started using this SGLT2 inhibitors in patients who have got acute myocardial infarctions and those who are deteriorating heart failure in the hospital setup. As well as the outpatient department. So we are using this. And obviously the patients who have got multiple risk factors for cardiovascular disease as a primary prevention, this has been not very commonly in use, but we have started using it.
Sanjeewa. Chandrike would you like to enlighten us on the dosing of SGLT2 inhibitors for cardiovascular protection?
If you look at studies available, EMPA-REG is the one which compared two doses, 10 milligrams and 25 milligrams. And there was no statistically significant cardiovascular benefit between the two. Therefore, I think 10 milligrams is the way to go for cardiovascular benefit for empagliflozin. And dapagliflozin has been studied at 10 milligram dose, and which shows good cardiovascular benefit. Again, dapagliflozin also, it's the 10 milligram dose that we have to go, I think. EMPA, there's not much benefit in increasing. Personal experience is also that there's not much benefit in increasing to 25 from 10, other than adding to side effects.
Also, Chandrike, what do you have to say about, adjusting the doses of SGLT2 inhibitors, like when there are concurrent medications going, for example, diuretics, antihypertensives?
Cardiac patients are on multiple medications, particularly patients who have been treated for heart failure. They are on ACE inhibitors, diuretics. So you have to be conscious about the diuretic effect and the hypotensive effect of empagliflozin and dapagliflozin when you start it. Therefore, you may have to reduce the dose of the diuretics and antihypertensives, particularly the ACE inhibitors, particularly in the group where the blood pressure is borderline, where they are just hanging on with the blood pressure when you are starting these molecules, SGLT2 inhibitors. And also I'll be very cautious on starting ACE inhibitors and SGLT2 inhibitors together. So I will first start one of them and then start the other, because you should be concerned about the initial drop in GFR, though it's beneficial in the long term. So I would adjust particularly my diuretics and the antihypertensive medications when I'm starting SGLT2 inhibitors. And also sometimes you have to assess the patient's hydration status as well, particularly in these patients. If they are over-diuresed already, I'll be a bit cautious in starting. First, I will correct the hydration and then start on SGLT2 inhibitors.
Chandrike, do you expect, the first dose, the concept of first dose hypotension?
No, not the first dose hypotension. It's not as if in ACE inhibitors and ARBs, but initially there's a drop in GFR. That's what I'm worried about.
I would like to ask Dr. Chula Herath. So, how do you utilize SGLT2 inhibitors in your renal patients in order to get the maximum benefit?
Well, SGLT2 inhibitors have quickly become one of the most important drugs in the armamentarium of the nephrologists to reduce slowing down deterioration of renal function. Actually, when I was seated here, I was counting 7 possible benefits of SGLT2 inhibitors to the kidney. Number one, of course, is the glycemic control, the benefit from glycemic control. Number two is the reduction of intraglomerular hypertension, as Professor Lean so elegantly demonstrated. It reduces the blood pressure inside the glomerulus and reduces further deterioration of renal function. It slows down the progression of CKD. That's number two. And number three, of course, is reduction of the blood pressure. Number four, it's very important to know that SGLT2 inhibitors actually reduces potassium. It's one of the most important drugs in treatment of hyperkalemia. It has been highlighted recently. You know that there's a subset of diabetic patients who get hyperkalemia very easily with ACE inhibitors, that is even with normal renal function. Those are the people who get type 4 renal tubular acidosis. And when you combine the ACE inhibitor with the SGLT2 inhibitor, the hyperkalemia gets less. So that's number 4. Number 5 is, of course, weight reduction. Number 6 is to reduction of sodium, so that fluid retention is alleviated. And what's the number 7? I can't remember the number 7. Uric acid, that's right. Good. It reduces, yeah, the protein reduction comes through with the reduction of pressure. The number 7 is the recent, they have highlighted that it reduces uric acid. Right, because it reduces uric acid reabsorption in the tubules as well, so that there's the hyperuricemia is alleviated, which is important for, again, slowing down this progression of renal disease. Right? So, we were talking about this reduction or dip in the EGFR with the SGLT2 inhibitors. I think that is especially the endocrinologists overreact to this, right? Because the dip in the long-term studies have shown that usually, unlike with ACE inhibitors, where the dip can be very sharp, but the SGLT2 inhibitors dip is not very sharp, right? And the studies, especially the DAPA-CKD and the DEMPA-CKD trials have shown that the people who have the greatest dip benefit more with regards to slowing down of the deterioration of renal function. And so if you have more than 30% drop, what I would do is to see that the patient is hydrated well and redo the serum creatinine, right? But as far as the studies show, they have never shown creatinine rising from 1.2 to 3.5, for example. Right? It can go up to from 1.2 to 1.4, right? Not more than that. But then you should just watch without stopping. Yes.
Make a comment on that? Yeah. To further on that, sometimes we say this is good for your kidney, and then you give it to them, and then you measure, and it goes down. And they say, you lied to me. You said it was good for my kidney. So what we have to do is tell them that we're taking away the pressure that's in the filter. So when I close the pipe down, now there's less pressure, so your speed of the filter is going to slow down. Just like if I limit the number of patients that come to your office, then your speed will go down, but you'll last longer, right? You will last longer because you're not going like crazy, right? So think of that. It's a very easy analogy, okay? So that's why when we close the pipe down back to normal, then basically we take the pressure off. So yes, you're going to see the EGFR come down a little bit, but in the long run, we're protecting the workers, just like protecting the doctors or whatever. So I think you can figure out what analogy you use, but I think for us, the doctor is very simple. So I think that's good. And I think the nephrologists have been leading the way in this area because many of us don't understand this stuff, right? We get very nervous about, so now I tell people don't measure the EGFR after SGLT2. You don't need to. And you can understand why it's working on the in-pipe, the ACE inhibitor is working on the out-pipe. The problem was we said the drop is like ACE inhibitor drop. That's what got people all nervous, right? Because we said, oh my God, the ACE inhibitor drop was scary and all that kind of, it is not like ACE inhibitor drop at all. It's just doing the in-pipe and that's it. It's not touching the out-pipe. It doesn't do anything with renal artery stenosis or any of those crazy things that you remember. And I think that would be very useful for us to get across. And I've started to tell people that we do studies on people. Okay, so I tell people 10,000 people like you took this drug and they had less kidney problems. I now say that. The reason is because patients don't know that we study these drugs. I remember for the ARBs, right? I had a sample in my cupboard, and I was so happy back then. This was, what, 20 years ago. I had a sample. I gave it to the patient, and I saved him $50. I was so proud, you know? And he went out to my secretary. He goes, I don't know about Dr. Lin. He's giving me experimental drugs from his cupboard, okay? So, like, they have no clue, right? So now I tell them, we looked at 10,000 people like you, and the people that took this had less kidney problems, less heart failure. And then they know that, okay, this is tested, like you've actually looked at it. And I think that's very helpful for people. Whenever you're dealing with different dosages, thankfully here it's 10, right? It's very simple. But let's say you're doing insulin. I now tell people, for your weight, you need 40 units a day. But we're gonna start just at 10, and we're gonna go up. So by doing that, I tell them, this is where you need to be. I'm gonna start you here, and I'm gonna slow you, move you up. Without that, everybody stops at around 20 units per day because they're thinking, I'm taking double what he started me on. So something's gone wrong. So we have to tell patients, atorvastatin, I tell them 80 milligrams is the highest, I'm gonna give you 10, and then we'll work our way up. So that way they feel that, oh, 10 is very good. So these are simple tricks that we can use to help patients understand as well.
Do you think we should put it in the municipal water supply yet? No?
Definitely not in the municipal water, like just put it in the water and everything. And this was the same story we had statins, right? Remember statins? We said we should just put it in the water and put it in the polypill. So in the appropriate patients, so at risk, putting the medication is good. If I give it to a 20-year-old that's healthy, all I'm gonna get is side effects, right? So I think that as physicians, we still have to think, but it's starting to be easier. And the cardiologists in Europe have been very aggressive, right? They said that if you have diabetes for 10 years and just one risk factor, smoking, blood pressure, anything else, you're high risk, you should be on an SGLT2 or GLP-1 first line, and then metformin afterwards. So they were very aggressive. But for the rest of all of the diabetes world, it's always metformin first because that's our friend. For 100 years, it's been our friend. So I think metformin and then quickly the SGLT2 on top, that would give the package. And as far as cost, I look at it this way. One pill is now doing multiple organs, which is a poly pill by itself, right? As opposed to needing a bunch of different pills. So we haven't seen this since ACE inhibitors, where it could do, ACE inhibitors did stroke, heart attack, kidneys. Statins could do stroke, heart attacks. Kidney was not so big, but now we have sort of heart failure, cardiovascular death, and also kidney as well. So, you know, these are the drugs that might be good for your patients, like cost effective, I guess that's the word.
So my nephrologist colleague will be very happy because he's getting less referrals from me now. And one follow-up question, how comfortable are you at lower GFRs, giving SGLT2 inhibitor?
Well, yes, now we have come down gradually up to 20 now, but now there are studies going on, two big studies are going on, I think EMPA dialysis and EMPA HT and DAPA HT studies, which in where they give the two drugs to dialysis patients. And there are some small studies which have shown that in dialysis patients, actually, it preserves the residual renal function, which is very important in patients with dialysis. So probably, you know, I mean, if we now presently we give the drug to patients who are actually stage 5 or so, if we started it before eGFR of 20. So I think, you know, probably in the future it will be useful in dialysis patients as well, because some studies have shown in peritoneal dialysis as well as hemodialysis patients that it really is beneficial, especially the cardiovascular benefits. Yeah.
Thank you, sir.
Just if I ask a question from Peter, now, because accordingly, now the practice is if you have started, then you can go on up to till about the dialysis. I'm just trying to figure out in my own brain, like, you know, because it acts through the functioning the nephrons. So if your nephrons are so depleted, are there any other mechanisms by which the benefit is maintained?
Yeah, there's a lot of mechanisms. Some people think it changes the fuel that we burn. So the ketones that it generates may be a good fuel for your heart, for example. So there's a lot of mechanistic things that people are going for. And I think that's why we like to show you the data. We're going down to eGFR of 25 in DAPA-CKD or 20 in EMPA kidney. There's still benefits going on. So it may be partially management of sodium, but it may be also partially these other energetic things, like what kind of fuel you burn, that seems to be helpful. And there's lots of people looking at these mechanistic studies, but those ones is like 50 patients, you know, that you look at. And I often tell people, we don't know the mechanism for everything. Like I think ACE inhibitors, we thought we knew, right? You block the ACE enzyme, you make less angiotensin 1, less angiotensin 2, and therefore less blood pressure and all that stuff. But if you look at the studies, you give ACE inhibitors, angiotensin 2 drops, 3 months later it's back up to normal. So it has nothing to do with angiotensin 2. But we do know that ACE inhibitors reduces stroke and heart attack and death and kidney disease. We don't understand the mechanism, but we still keep giving, right? So in this particular case, I think if the dialysis studies come out and it's positive, we'll say, we're not exactly sure what it is, but let's give the benefit to these people, you know, that we have.
Later on, we found that ACE inhibitors actually reduces the fibrosis-inducing agents like TGF-beta. And now, even for SGLT2 inhibitors, they are gradually finding out that it reduces the inflammatory markers, as well as substances like TGF-beta, which is the fibrotic molecule in both kidney and as well as the heart and the lungs. Yes.
I think a very short question. You brought out a very important thing which we have forgotten, the ketonemia. I think we have discussed in surface as well. I saw a paper. It's coming, no? Yeah, it's coming. Okay.
So, Dulani, so what is your take on diabetic ketoacidosis and SGLT2 inhibitors?
Yes, Tharanga, because we are now seeing a lot of patients on SGLT2 inhibitors, we are seeing a bit of side effects of it as well. So euglycemic ketoacidosis is due to lowering of blood glucose because we are now passing glucose in the urine, and low insulin as well. Because of the low insulin levels, we are getting high glucagon levels, which will also lead to increase in lipolysis and more ketogenesis, having keto acids in your blood. So these patients typically will come up with symptoms of mainly acidosis, not symptoms of hyperglycemia. So you have to be very careful in detecting these patients because they'll just feel nauseated, vomiting, feeling of vomitishness, and also they'll feel unwell. So if you come across patient who's on empagliflozin or dapagliflozin having these kind of symptoms, be careful and make sure you do the ketones and you do a blood gas if the patient is already in the hospital, and manage them properly, because we have to give insulin to these patients, but we have to start in the middle of the regime with insulin plus dextrose for these patients because they are euglycemic. But you have to manage them properly with IV hydration as well. And we have to prevent this as well, happening euglycemic ketoacidosis. And important thing is to tell this patient to, if you are having acute illnesses, to stop it prior, stop it with the illness, and also prior to surgery, you have to stop the SGLT2 inhibitors also. That is to prevent them going into euglycemic ketoacidosis. I would like to ask Dr. Lin also, is it common there? Do you see patients with euglycemic ketoacidosis, Dr. Lin?
Yeah, so it's actually very rare. So that's why when I run into some physicians, they say, we see every day diabetic ketoacidosis. I say, every day you see it. And what they're saying is that a person on SGLT2 vomiting, in their mind, is ketoacidosis. That's not ketoacidosis, right? So therefore, we just have to be careful not to overcall it. In the clinical trials, it's less than 1%. And if we manage it well, the key thing to tell your patients, let's say they're on insulin. DKA is always lack of insulin. Okay, no matter how you look at it, it's always lack of insulin. Then your body has no insulin, so the sugar doesn't go into the cell. So now you cannot use that as fuel. So then you start breaking down fats, making ketones, using fuels that don't need insulin. And that's when you get into trouble. So all DKA is because of lack of insulin in some form. The most common one initially is patient taking insulin, type 2 diabetes patient taking insulin, takes the SGLT2, their sugar becomes good, and they think they're cured. So they get rid of the insulin. And when they stop the insulin, they get into trouble. So now I tell patients, your sugars are going to come down, but remember, insulin does one job. It's to move sugar into the cell so your body can use it. Nobody else can do that job. So even if your sugars come down, you might need less insulin, but you always need insulin on board. So that way, if we explain that right off the top, then they're not going to stop their insulin. This is why we got into trouble with type 1, and that's why we don't use it in type 1, because the type 1 kid said, I'm cured, and then they stopped their insulin, and they all got into trouble. The other trick with this one is that if it is true DKA, then the sugar will be low or normal. And the reason for that is because in normal DKA, no insulin, right? So then the sugar is very high in the blood. It cannot go into the cell. So normally we're looking for high sugar. But if there's an SGLT2 on board, you've peed out all the sugar. So you got it through the kidneys and got rid of all the sugar. So that's why the sugar will look not that high. And that's also why, as she was mentioning, you have to give them sugar when you're treating them. In the normal DKA, you don't have to give them sugar, right? Because the sugar stayed in the blood. You give insulin, and the sugar now moves again. But in this case, you peed out all the sugar, so your body is missing sugar. So what happened in the beginning when we gave them insulin and fluid, they went hypo, and then they got into a lot of trouble. And that's why people said, ooh, euglycemic DKA is very scary. Not scary. You peed out the sugar. I need to give it back to you as I'm giving you back your insulin. So it's not complicated, and you're not going to see one of these things. So just remember, vomiting in SGLT2 is not DKA, okay? So that's one of the symptoms of it, but I think a lot of people were tagging that as DKA, and I was shocked to, people were saying, yeah, we see 2 a week. And I said, the clinical trial program, they have never seen that kind of rate. And then when I asked them, did you measure anything? Oh, no, we measure urine ketones, but they're going to have urine ketones, right? And then they said, but they were vomiting. But I said, did you do the blood? Did you do acid? No, we didn't do any of that. And they just labeled it as euglycemic DKA. So nausea, vomiting is not the same as DKA.
Thank you, Peter and Dulani. So it's an honor having Professor Sanjay Kalra, the president of the SAFIS, South Asian Federation of Endocrine Societies. So he would be delivering the concluding remarks of this the panel discussion, showing us the South Asian perspective of this.
Good morning, everybody, and thanks to everybody who is here with us on an early Sunday morning. Thanks to our speakers as well. What I learned from Dr. Peter was today, how do you translate tertiary level therapeutics into very comfortable conversation on the ground? I think that's what we learned from you. That's one take-home message. How do you convert all that difficult science, the difficult jargon, into something that your patient can understand? Let me share a few South Asian perspectives which are relevant across the globe. The first is when you read the Bible, if you were to go into the Bible, then there is a book of Revelation. And what Jesus says is, you will be judged by the state of your kidneys. I will search your heart, I will search your mind, and that will tell me what I have to do with you. Now, of course, earlier, the word rein, R-E-I-N, the kidney was considered the seat of the soul in the Bible, in biblical times. So if you want to be judged properly, you make sure your kidneys are fine and your heart is fine. There is also allusion to the cardiorenal syndrome in the Bible, because whenever they speak of the heart, they speak of the kidneys as well. Whenever they speak of the kidneys, they speak of the heart as well. The beauty is the order as well. First they speak of the heart, then they speak of the kidney in the Bible. So that's why we also call it cardiorenal syndrome. No offense to our colleague from Nephro, but we never called it renocardiac syndrome. So that is the first take-home message, that you will be judged by the state of your heart and kidneys, but more important than that, we will be judged by the state of our patients' hearts and kidneys. So we have to take care of them. The second take-home is something called resilience. Now, Dr. Peter said that it would be nice if we have the same drug for prevention and for cure. That is known as the law of therapeutic parsimony. Therapeutic parsimony means you use one drug and you give multiple benefits. So it's not about a 300 rupees coffee. How much satiety are you getting from that coffee? So how much satiety, how much benefit are you getting from one drug? So to prevention and cure, when we speak with our patient and say, I am giving you this medicine to manage your diabetes, that's just one point. But if I say this medicine is going to prevent heart disease, kidney disease, that's the second point. We can improve that sentence as well. So let's talk about youthfulness, longevity, resilience. Resilience is a word that strikes a chord with every Sri Lankan and every Indian. Because that's why we survive. So this drug is going to make your heart and kidneys younger, more youthful. They will last longer. You'll be able to run a marathon. And they will add resilience to your kidneys. That is the second take-home message. So we should learn how to speak these in Sinhala and Tamil. And perhaps Dr. Peter, by next year, will learn a little bit of Sinhala and Tamil so that he can do a better job of teaching us next time. Speaking of resilience, the third take-home that I have is something called the Robin Hood hypothesis. Now, in India, you're aware about, I think 7 or 8 years ago, we had what we call notebandi. We had demonetization. Overnight, our economy collapsed. What we realized was that there is a need for a Robin Hood kind of a person in our economy. So what Robin Hood used to do was he would steal from the rich and give to the poor. Suppose, and there was a sheriff of Nottingham also, he was the villain, but there was a balance, there were checks and balances. So if Robin Hood were to continue all his activities unchecked, then also the economy will collapse. But if there is a balance, then things are fine. In India, what happened was, overnight, some of our sectors collapsed, like construction, real estate, and jewelry. The black economy vanished because there was no notes, no cash, and people got into trouble. So now, supposing for Sri Lanka and India, you have only black economy. Nobody pays their taxes. All the money goes to Switzerland or to Canada. Then we are not going to survive. But at the same time, if you don't allow informal economy for the vast majority of our population, for the indigent population, then also we collapse. What does all this have to do with SGLT2 inhibitors? SGLT2 inhibitors are a Robin Hood kind of a drug. They steal from glucose metabolism and they give to fatty acid or ketone-based metabolism. As long as that is done in a regulated manner, you are able to increase efficiency of the glomeruli, you are able to increase efficiency of the myocardiocytes. So you end up having more resilient, more efficient kidneys and hearts. This is called the Robin Hood hypothesis. If, however, it is done in an unregulated manner, then we get in trouble. Then we get the diseases like euglycemic decay. So the point is choosing the right person, the right drug for the right person. Just like for economy, if you want to go to Barista or Java, then you will pay your GST, you will pay extra tax. But if you're on the roadside and a village woman is selling you coconut, king coconut water, then you're not going to tell her, I want to pay with my credit card or debit card. So this is what SGLT2 inhibitors bring to us. They bring added resilience, added advantage, provided that we are able to use them in a responsible manner. 2 more take-homes I have. How do we use them in a resilient manner? We know the indications. They are indicated for everyone with type 2 diabetes. The studies are there now. They are indicated for people with pre-diabetes and non-diabetes as well, if you want to focus on heart and kidney health. But more important than that is knowing the contraindications and the caveats. So they have all mentioned them. Let me just repeat. Anybody with even a single episode of upper UTI, the drug is contraindicated. Anybody with recurrent, resistant, refractory UTI, resistant, recurrent, refractory genital tract infection, the drug is contraindicated. What is the definition of recurrent? 4 times a year, 2 times a year, so we take 4 times a year, but it depends upon the quality of life. Now, a newly married gentleman with melanocystitis, a young girl with pruritus vulvae, what impact is that having on his or her life? That we have to keep in mind. So I would strongly suggest that we keep these things in mind when we prescribe. We are speaking of contraindications and caveats. DKA is something that is important. So when I began practice, Dr. Peter, I used to see 4 or 5 DKAs every day in my OPD. A with capital A, acidosis, because I went to a part of the country where there was no diabetes or no endocrine care. Now I don't see them. Now I still see DKA with the small a. So it's diabetic ketosis, but there is no clinical acidosis. 3 things you should remember. Why will ketosis occur in anybody? That is when Robin Hood acts too much and when there is no sheriff left, there is no glucose metabolism left to counteract. So if there is inadequate fluid, water, inadequate carbohydrate, sugar, and inadequate insulin, whether exogenous or endogenous, we are going to get in trouble. So when you prescribe SGLT2 inhibitor, make sure you don't do it in a state of acute instability. There are other drugs to give. Insulin is there. Once your patient has become stable, then you prescribe. But do remind your patient, drink adequate water, take adequate carbohydrate, minimum 100 grams a day. That is not an issue in Sri Lanka because Dr. Peter has also realized we have the tastiest food in the world. So the Canadians don't have, that is their kismat, their vipak, not ours. So, make sure that the carbohydrate intake is adequate and let the patient not suddenly go on a keto diet or intermittent fasting without telling you. Also, adequate insulin, whether endogenous or exogenous, has to be maintained. So if your patient is insulinopenic and you are not prescribing insulin from outside, you decide to add to somebody with LADA, you decide to add dapagliflozin, the patient is certainly going to go into trouble if the patient is not being treated with insulin. So these were some things from a South Asian perspective. Like we said, we are a resilient part of the country and we have a very strong culture, strong tradition. There is one aspect of Sri Lankan religion and tradition which has influenced me a lot. I have learned from Dr. Manilka and Dr. Dyakshi Aberatne. So would any of you wish to speak about metabolic vipak? That will be our concluding statement for this panel. Madam?
You can go ahead. No, you go ahead.
So this is for,
Read a paper on metabolic.
not so much for all of us, but more for Dr. Peter. Vipak means destiny, outcome. In Hindi and Sanskrit, in Pali, we use the word karma or kamma. Karma or kamma can be past tense, present tense, and future tense. Whatever happened in the past, whether we were taking generics or not, whether we were taking SGLT2 inhibitor or not, whether the patient was smoking, drinking, doing whatsoever, that is the previous kamma, previous karma. You cannot do anything about that. That action has influenced today's state of health. Maybe today the patient is in a state of heart failure or the patient is in CKD stage 3. Can we do anything about this? The answer is yes, we can. We can take charge of our destiny. In the West, they use the words glycemic legacy, metabolic memory. These words may be new in the English language, but our tradition is 2,500 years old. And we use the word metabolic vipak. Metabolic vipak means that you take the right drugs at the right time for the right duration. And then you will get beneficial outcomes. That is the advantage that SGLT2 inhibitors bring to us. In the Hadith, it is mentioned that the Prophet has said, there is a cure for every disease except old age. I am not saying it, our colleagues are not saying it from cardio-nephro, the Prophet said it. So when old age comes, it will come. Right now we are young. Somebody may be 50 years young, like some of you, others may be only 25 years young, so you have actually less experience of youth. Some of us on the stage, we have got 60 years of experience of youth. So we are still young. So when old age comes, it will come. Till then, we will take the best possible drugs, which might mean aspirin, which might mean statin, which may mean SGLT2 inhibitors also. That is metabolic vipak, and that is the strength we should be able to share with our patients. Thank you.